joining us. Thanks very much for joining us for this webinar of the Center for Research in Health Systems Performance. My name is Jose Maria Chema Valderas, and I'm the director of CRiHSP. It gives me a great pleasure to introduce our speaker today, Dr. Michael Anderson. Michael is a National Institute for Health Research academic clinical lecturer at the University of Manchester and a visiting fellow at the London School of Economics and Political Science. He's also a senior expert advisor at the European Observatory of Health Systems and Policies. His research takes an international perspective and is focused on the following areas relevant to health economics: the public and private interface, workforce planning and strategy, pharmaceutical policy, including antimicrobial resistance, and disinvestment from low-value care. He has co-research led. He was co-research lead for the LSE Lancet Commission on the future of the NHS, and is author of the 2021 PHSSR report and the 2022 UK Health System in Transition report for the European Observatory of Health Systems. Michael, like myself, although that was not part of the update, he's a GP, and we have worked on and off on a number of initiatives, and I'm delighted that he accepted our invitation to give a talk on this exciting topic about the future of the NHS in the UK, and I'm sure you will enjoy his presentation. Just a request: if you can please withhold your questions till the end, and also feel free to use the chat for asking those questions too. But of course, also we raise your hands. Well, without further ado, Michael, over to you.
Okay, great. Thank you, Chema. So I'm delighted to give this talk today and talk about some of my experiences in assessing health system performance, but in the UK context. And I hope many of the lessons that I've learned focusing on the UK healthcare system can be applicable to the Singaporean context. So this title, The Future of the NHS, No Longer the Envy of the World, it's quite a provocative title. So it stems from Anura Bevan, the politician that drove the establishment of the NHS. Back in 1948, he made the bold claim that the NHS would make Great Britain the envy of all the world. And for a period of time, it could be argued that was the case. However, in recent decades, things have changed. And I'm hoping from the talk today that I can give you a perspective on some of the strengths of the NHS in the UK and that model of organising a healthcare service, and some of the weaknesses and some of the policy priorities moving forward. So you've already given an excellent introduction to who I am as an academic. It's, essentially I'm a primary care academic interested in health policy and economics. But what I particularly enjoy is that, as you mentioned, a lot of my work takes this international health system comparative perspective. So I like to understand which aspects of healthcare organisation, financing and service delivery impact health system performance, the end outcomes, whether it's health outcomes, efficiency, equity. And we'll talk about some of the frameworks that have been used to answer those questions. And it's mainly from these three exercises that I've gained these insights into the UK healthcare system. So it started with the LSE Lancet Commission on the future of the NHS. And then we undertook a report for the Partnership for Health System Sustainability and Resilience. And finally, myself and co-authors published the European Observatory on Health System and Policies UK Health System in Transition report. So I'm going to talk about some of these initiatives, which are all still active, and some of the different methods that they've used, their scope and their remit, because I think they could be used as a foundation to apply similar frameworks to the Singapore context. So what was the LSE Lancet Commission on the future of the NHS? So it was founded at the 70th anniversary of the NHS, and the remit was to think about a long-term trajectory and what the priorities were to strengthen the sustainability of the NHS. the pandemic happened and the shift changed, and we didn't just have to think about the long-term perspective, but also how we responded to the pandemic, what the strengths and weaknesses were, and what we can learn for potential future acute healthcare shocks. So in all of this work that I've described, this was, I've always worked with Professor Elias Mosialis and Alistair Maguire from LSE, Professor of Health Policy and Professor of Health Economics, and also worked with Emma Pitchforth on throughout these initiatives. The LSE Lancet Commission had a UK focus. It had 27 interdisciplinary commissioners from healthcare management, frontline clinicians, health policy experts, epidemiologists, to give us a broad focus. But we conducted our analysis based on a literature review of previously conducted reports that have looked into the NHS, also existing indicators of health system performance collected by multilateral initiatives and NGOs and organizations like the OECD, the WHO, the World Bank. But we also we had a very broad consultation where we had an open call for evidence with 33 submissions and evidence hearing. And then we had targeted meetings with 76 different individuals representing a broad range of different institutions. And the resulting product was the main commission report, but then a series of targeted papers that focused on different aspects of health system performance, whether it's the workforce, whether it's healthcare financing, whether it's digital health, or the changing demography and changing healthcare demands. And the findings of the commission received high-level media attention. So we were featured on the front page of The Guardian. We were also featured in The Independent and The Times. And if you track our recommendations, you can see that many of them have been implemented since. And we're currently in the process of looking at the 10-year plan and mapping that against our recommendations in the LSE Lancet Commission to see what is yet to be realised and what has been achieved so far. So moving on to the Partnership for Health System Sustainability and Resilience. So this is relevant to Singapore because I'll talk in a moment about how this particular initiative is active in Southeast Asia. So the Partnership for Sustainability, it's a non-profit organization and partnership between a range of different institutions and organizations from academia, public and private sectors. And essentially it's focused on trying to produce health system reports that identify policy recommendations to strengthen the sustainability and resilience of healthcare systems. And so far, 25 country-specific reports have been published, and a range of high-level reports that compare and contrast findings in relation to specific health system reports have also been produced, and also separate reports focusing on specific disease areas like cardiovascular disease and diabetes have been produced. But a big aspect of the Partnership for Health, Sustainability and Resilience is this knowledge brokering function, where they use a range of different platforms to try to disseminate the findings from these reports, whether it's the World Economic Forum, the Expo, the World Health Assembly, or the World Health Summit. And they've had high-level government and ministerial engagements in almost 40 countries. So what's next for the partnership over the next 12 months? So they want to continue expanding their health system reports to a range of different countries. As mentioned, there's 25 countries so far, but they want to try to reach as many countries as possible. And they'll also begin to start updating health system reports on a 4 to 5 year basis. They're also focusing on specific issues, and what's been highlighted as a priority amongst the different members of the partnership is focusing on non-communicable diseases. So there's currently 8 country-specific reports on acting early on non-communicable diseases, as well as a global summary report that will be launched at the beginning of next year. And they're going to continue to leverage these platforms that I've mentioned to try to promote dissemination and engagement of policymakers, but also working on a range of different social media platforms and media engagement through the recruitment of a communication officer And the ultimate ambition is to establish a Partnership for Health, Sustainability and Resilience Centre based in the LSE. So how are they performing these UK health system and reports under the partnership? So they've produced this particular framework, which was produced based on a literature review of existing health system frameworks and a range of different stakeholder interviews to test and refine the framework before it was deployed. Some of you will recognize some of these aspects in the World Health Organization health system beyond that. The population health gives a contextual background to what challenges the health system is facing in relation to the burden of disease or personal risk factors, environmental risk factors, and social determinants of disease. And these key health system functions in the middle, governance, finance, and resource generation, are aligned with the WHO approach. Service delivery that's focused on how services are organized and delivered, whether it's through guidelines or risk assessment and diagnosis and referral and secondary prevention and treatment. Now, there are intermediate outcomes and end outcomes. So the intermediate outcomes, equity and efficiency, people-centered care and access, contribute to the end outcomes, which are healthier populations, broader economic development, and improved labour productivity, environmental protection, and a sustainable health system that is resilient in the face of acute shocks to the healthcare system. Now, so what is the Partnership for Health, Sustainability and Resilience doing in the Asia-Pacific region? So the way that the partnership operates in this area is through the Centre for Asia-Pacific Resilience and Innovation. So some of you may be familiar with this centre. So it's Taiwan's first international NGO, and in collaboration with focused on health system sustainability and resilience. So in collaboration with the partnership and LSE, CRiHSP has led the development of a range of different health system reports in Taiwan, South Korea, Malaysia, and the specific islands of Tonga, Vanuatu, and the Marshall Islands. And a report of Singapore is on the way. So that's hopefully due at some point next year. The reason why this approach was taken is these health system reports require a policy expert or experts within each individual country to lead the development of the report. So it's very much felt that they need to be led by someone within the country so they can leverage their networks to help with dissemination. So whilst the partnership team is there to offer advice and technical input into the development of the report, it's important that it's seen as driven by stakeholders within the country, just because that seems to have better engagement with the policymakers, seem to be more engaged with the findings of the reports and implementation. So CRiHSP, they've identified these 4 main challenges that are facing health systems in the Asia-Pacific region, talking about the context that these health systems face, and it's aging societies, and that's specifically not just the fact that the population is getting older, but we have low birth rates in many of these countries, which creates significant challenges in terms of resource generation and financing of the healthcare system, because often the tax base is decreasing whilst the demand is also growing simultaneously. And also many of these countries are facing distinct issues created by climate change, whether that's persistent flooding or higher temperatures leading to increasing prevalence of heat waves and the associated disruption to healthcare systems and that associated with these, as well as trying to manage digital health, which itself can drive demand, but also in certain contexts can also help promote the efficiency of the healthcare system, also whilst managing equity implications caused by digital exclusion. And like many countries, also the healthcare systems in these areas are facing recruitment and retention issues with the workforce, as well as broader challenges in relation to workforce planning and optimizing skill mix. So I'll just touch very briefly on this. The last exercise was a UK health system report conducted for the European Observatory. So the European Observatory is an interesting institution to look at because of its longevity. So they've also had, it's 25 years old now, and they have a very long, all of these initiatives have similar objectives and remit, but the European Observatory stands out in particular for their strong record for influencing policy through health system performance assessment, policy analysis, and knowledge brokering with policymakers. And it's an institution that is embedded within WHO Euro. So it's a WHO Euro unit that Professor Valderas knows well, because with his previous engagement with the observatory. And it's a collection of member states and EU institutions and policymakers and academics who are focused on promoting health system performance. And there is a range of different institutions that are involved. So as I've mentioned, it's centered in WHO Euro with involvement of the European Commission, and a range of different European governments contribute either financially or in kind to support the European Observatory. And the European Observatory has a strong record of leveraging European Union presidencies, which are rotated between member states of the European Union every 6 months, where they're given a platform to raise attention to major public health issues. So I wanted to just shed a light on the European Observatory Health System Performance Framework, which has evolved iteratively over time, over the 25 years that the European Observatory has been functioning. And you may see some similarities to the Partnership of Health System Sustainability and Resilience framework, in that the health system functions are identified: governance, resource generation, service delivery, and financing. And there's a series of intermediate objectives of the healthcare system related to access, effectiveness, safety, patient experience, efficiency, and equity that lead to the final goals of the health system, which are people-centeredness, population health, and financial protection. But they've complemented it with these broader societal goals, which is economic development, social cohesion, and well-being. So I won't spend too long. I could do a whole presentation defining all of these various concepts. I wanted to just shed a light on the different frameworks that are used, and the relevant references can be reviewed. But I think if you were to apply some of these frameworks to the Singapore context, I would advise potentially using either one of this framework or the one from the Partnership of Health System Sustainability Resilience, or perhaps merging them into a single framework to guide such assessment. Now, the end outcomes of these 3 initiatives are these 3 reports, as I've mentioned. So there was the LSE Lancet Commission on the Future of the NHS, the England-specific Sustainability and Resilience report for the Partnership of Health System Sustainability and Resilience, and the UK Health System Review. And whilst they have slightly different remits, they were conducted at a similar time. And what I've done is I've produced, and the subsequent slide shows an analysis that merges the main findings across these reports. So I think it was just important to give you that background regarding these initiatives, which I thought you might be interested in understanding before I delve into the analysis. But this is the bit that I find most exciting, where we start to get into the nitty-gritty of the weaknesses and strengths of the UK health system. I'll just give you just a bit more context on the UK healthcare system, which is obviously very different to the Singaporean healthcare system, which obviously has a much higher privatized financing element. There's also medical savings accounts. You have a strong history of public-private mix in terms of provision, where the UK healthcare system is a national healthcare service. So what that means is that it's a centralized system with a single payer, the National Healthcare Service, and the resources are generated through progressive broad-based taxation. So we don't have any earmarked taxation for the healthcare service. It comes from general taxation. So that means that we have to compete for other the opportunity cost against other priorities of public spending. And we have resource allocation centrally to a range of local commissioning bodies, which then contract and commission healthcare services locally. Now, the one thing to point out is I keep saying the UK healthcare system, but in reality, it's 4 separate systems. So since the late 90s, there's been devolution, and there is a separate responsibilities for the healthcare service for devolved governments in England, Scotland, Wales, and Northern Ireland. But ultimately, the structure is vaguely similar in the 4 countries. You have a centralised body responsible for governance and delivery of the National Health Service. In England, it's now the Department of Health and Social Care, but NHS England has been abolished. In Scotland, it's the Healthcare Directorate. In Wales, it's the Department of Health, and in Scotland, it's in Northern Ireland, it's the Department of Health. And then there is local commissioning bodies which organise services at the local level. And we have a much smaller private element. So there's lots of discussion at the moment about how there's increased demand for the private healthcare sector. And there is some signals that that is happening to some extent. For example, people using remote services for primary care, or using out-of-pocket payments for elective care services. However, compared to other countries, we still have a very small private healthcare sector. Only around 20% of healthcare expenditure is private versus public, and the private medical insurance that exists is only supplementary, and it's for 12% of the population. So how does the UK compare to other countries? So remember that background I gave you at the beginning of this talk. The UK was established, the UK healthcare system, the NHS, was established on this premise that it would make Great Britain the envy of all of the world. It was meant to be a high-performing healthcare service with access based on clinical need, not ability to pay. And it was meant to be a high-performing, efficient healthcare service. However, unfortunately, what we've seen is that the UK underperforms in a range of different health outcomes. So, for example, if we look at life expectancy, we have one of the lowest life expectancies when compared against other comparable high-income countries. And we use the E15 and G7 countries as examples. So we are only just above Greece, and then obviously the United States is an outlier. We also have poorer cancer outcomes than most other high-income countries, with the exception of some hematological malignancies. And we have widening health inequalities, driving now decreasing life expectancy. We also, compared to other high-income countries, we also underfund our healthcare service. So if you look at the UK, there are many other countries that spend a higher percentage of their GDP on healthcare, whether you're looking at Canada or Austria or Japan or Germany or France. And we sit just above the EU15 average, but below the G7 average. We also have this feast and famine approach to our funding settlements, where we go through long periods of time where we have real-term increases in healthcare spending of maybe 5–6%, and then it drops to maybe 1–2%. And this pattern has happened ever since the establishment of the NHS, ever since the 1950s, which has really hampered long-term financial planning. And we also see that there are reductions in social care funding relative to the healthcare sector, despite the integrated nature of the health and social care system. Now, whilst we have seen health spending increase over time, when you map this against the changing demand for healthcare, the picture becomes even more dire. So if you actually adjust for the changing age in the population, you will see that in the 2010s, healthcare spending was essentially flat, followed by these large increases during the COVID pandemic. But when you look at the social care spending, it becomes even more dramatic. So whilst it was relatively flat during the 2010s for health spending, there were significant reductions when you look at age-adjusted social care spending. And this has knock-on effects for the efficiency of the healthcare service, because we see hundreds of thousands of delayed transfers and discharges from hospitals because the social care system doesn't have the infrastructure to manage demand for long-term care. Now, we are also particularly unique in the respect that we have lower numbers of doctors and nurses than other countries. If you look at many other countries, you often see the inverse between the two. So, for example, Italy has higher numbers of doctors but lower numbers of nurses. So there's obviously some substitution in tasks between doctors and nurses. So you see this pattern of so again, Denmark, high numbers of doctors but lower numbers of nurses. But in the UK, we see low numbers of physicians and low numbers of nurses, which implies that we have an understaffed healthcare service, and we're running our healthcare service on lower numbers of both doctors and nurses than other countries. And this is largely because we have kind of left healthcare recruitment to the open market. Essentially, there is a lack of long-term planning of the supply of the healthcare staff and the changes in demand. And actually, the 10-year plan recently said that they reject the previous workforce planning estimates, and that they don't see them as viable. And instead, they've asked staff to work to get more from staff, each individual staff member, over the next 10 years because of their push for improved productivity. So in general, they've rejected the concept of workforce planning. So I'll give you some examples of how this has played out in reality. So there's been one of the key, there are at the moment, the policy agenda is shaped by 3 shifts. So moving care to the community, shifting from treatment to prevention, and shifting from analog to digital. So you would assume that you would see an increase in number of staff in the community versus the hospital. But actually, we see the opposite. So we see a significant increase of nurses in the hospital, so in adult nurses, and a significant drop in the nurses that are working in the community, like the community nurses here, or learning disability nurses, or community health nurses here. It's even more dramatic when you look at the difference between hospital doctors and GPs. So if you look at 2010 to the current stock of hospital doctors, it's increased by about 65% and 26% in the last 5 years. So there's been a significant acceleration in the number of hospital doctors that are working. Whereas if you look at the number of GPs, in terms of their full-time equivalent, so that's the number of, this accounts for part-time working of GPs. So this is the number of full-time equivalent GPs. You see that it's actually decreasing over time, despite increasing demand for primary care. However, there are some strengths of the healthcare system. So if you look at our resource allocation system, we have one of the longest established resource allocation formula in the world. And what that does is it means the healthcare system works as a redistributive mechanism. We have progressive taxation where we tax the rich more than the poor, and then we use a resource allocation mechanism to redirect more healthcare resources to the poor and sick. So we essentially, it's a mechanism to move resources from the rich and healthy to the poor and sick. And this has been refined gradually over several decades. We also have NICE, so we have over the last 2-3 decades developed very robust and transparent approaches to health technology assessment, which when combined with other mechanisms such as high generic prescribing and competitive tendering of generics has allowed us to control our pharmaceutical spending. This has been controversial in recent times. Some have argued that actually we are too aggressively controlling pharmaceutical spending and it's impacting access. But nonetheless, we have shown that these mechanisms do help control spending. Whilst we do poor it in terms of life expectancy and cancer outcomes, we do comparatively better in a range of different chronic disease outcomes, whether it's kidney transplants or amputations for diabetic patients. And many people have attributed this to our relatively stronger primary care system. So despite the fact that primary GP numbers have dropped over time, we still have higher GP numbers than many other countries. And most people would agree that we have a stronger primary care system than other countries which have direct access to specialists and a much stronger focus on specialists rather than primary care services. And because of the centralized system that we have, where generally all of the NHS hospitals share similar institutional behaviours and cultural beliefs and objectives, and health information technology infrastructure, we are uniquely leveraged to set up large-scale clinical trials. So this was shown and demonstrated during the COVID pandemic with the recovery trial that identified many different effective treatments for patients infected with the COVID-19 virus. And we are increasingly looking at other opportunities to try to leverage this infrastructure to improve the efficiency and scalability of clinical trials, whether it's through pragmatic RCTs and leveraging electronic healthcare infrastructure. We also have one of the lowest levels of catastrophic health spending internationally. So this is a healthcare system where access is based on clinical need, not ability to pay. So generally our out-of-pocket expenditure is very low. It's normally concentrated within prescription costs, and of 90% of the drugs that are dispensed are not subject to prescription charges. So only 10% of them are. So as a result, we have one of the lowest rates of catastrophic health expenditure internationally. So this combines with that resource allocation mechanism I described before is what facilitates this redistributive mechanism that I described, from the rich to the poor and from the healthy to the sick. So the range of different we've outlined a range of different recommendations to strengthen our healthcare system to make it resilient and sustainable in the long term. And they're centered around these 7 areas. So funding, resource allocation, workforce, population health and diagnosis, health information technology, and integration. I may just stop for a moment because I'm going to move into the second part of the presentation where I talk about what needs to be done to strengthen the healthcare service. And just see, have there been many questions in the chat at this point? So
there aren't any questions so far.
Okay, so let's keep going. So and we can do questions at the end. So let's focus on funding. So I've mentioned one of the big issues is this feast and famine approach to funding, where we have stagnant funding, then we have 5 to 6% increases, and this impacts the ability to plan the healthcare service in the long term. So there's been lots of projections on what funding is needed in the UK, and they've centered on this 4% figure, which is 4% real terms annual increases. And throughout all our reports, we argued that the government should commit to long-term funding settlements over 5 to 10 years that implement this recommendation. And there needs to be a concept of parity between the healthcare service, social care, and public health and mental health, and primary care versus the hospital, where we don't see one increase at the expense of the other based on this fundamental principle. And we've also suggested that retrospective funding cuts in social care and public health are addressed. And one way of doing this is also aligning the social care funding model to the NHS. So currently we have significant out-of-pocket costs for social care in the UK. So we've suggested implementing a cap on those costs and also increasing the means tested threshold when you have to start paying. And this aligns the social care model with the NHS. However, this would be expensive, and we acknowledge this, but we actually went as far as mapping what is needed in terms of taxation revenues to implement these recommendations. And essentially it's a 1% increase in our 3 main tax categories, which is income tax, national insurance, and VAT. And then after 5 years, it's another 1% increase. This is politically challenging. And this does require policymakers to be transparent regarding what the healthcare resource needs are for the healthcare service that they want in the future. However, we would argue that it is financially achievable, because implementing these funding recommendations would, yes, increase the tax to GDP ratio, but only just above the G7 average, where currently we have one of the lowest tax to GDP ratios internationally when compared against G7 and EU 15 countries. So yes, resource allocation is a strength, but there are aspects of our resource allocation that do not function very well. So we do not have any independent analysis of the healthcare resource needs that inform spending reviews. We do have a broader institute, the Office for Budget Responsibility, that looks at broader public spending, but we don't have one specific to the healthcare service. And we argue that there is a need for this, and also to integrate that within our workforce planning, because at the moment there is a complete misalignment between the financial planning and the workforce planning, which leads to this context where we have an understaffed healthcare service. At the local level, I mentioned that some resources are allocated at the local level and then distributed locally. However, a lot of those decisions are made in a very non-transparent manner, and it leads to this so-called postcode lottery. So we outlined a series of resource allocation frameworks that could be used at the local level to try to improve consistency and access for different healthcare services and address unwarranted variation. But crucially, we argued that NICE, our body that appraises new technologies, needs to have their remit expanded to do the same for existing technologies. So we use the same approach to existing technologies, where we can assess their benefits in terms of quality adjusted life years, so we can take into account the opportunity cost of different investments, and also prioritize and rationalize our approach to reductions in low value care. From the workforce perspective, there is no long-term workforce strategy. So we argued for each country to maintain their own workforce strategy, England, Wales, Northern Ireland, and Scotland, but also on top of that, have a UK-wide workforce planning projection estimates, which take into account the changing workforce dynamics across each individual country, because there is significant mobility in doctors between these four constituent countries. But crucially, we argued that pay needs to keep pace with average earnings, and this would help overcome some of the issues related to junior doctor and strikes that have been hampering the healthcare service. But crucially, these long-term workforce planning estimates need to have assumptions inbuilt about task shifting between healthcare staff groups and technology, because currently the approach to changes in skill mix is taking place in a very ad hoc way without national oversight in terms of projecting what the potential is for substitution. From a prevention point of view, we argued that the government should start looking at prevention investments as a separate stream in their healthcare financing projections. And actually, we should have earmarked investments for preventative services and interventions, and it should be treated in the same way as capital investments. So with capital investments, the government projects the return on investment and develops a long-term plan for capital investments. We argued the same thing should happen for prevention. So prevention investments are targeted to those which have stronger return on investment, and any healthcare savings could be reinvested into this individual pool, this earmarked preventative investment fund, which could help strengthen investment in prevention and also ensure that investment in prevention is not deprioritized to other aspects of the healthcare sector. We also argued that each country, UK country, should have a health in all policy strategy, which identifies different aspects of public policy which have potential to improve population health. But crucially, that there is a UK-wide national approach to pandemic preparedness planning, which is completely transparent, where the exercises are published online for everyone to see the results and understand the assumptions, because part of the criticism of the UK response is that there was a pandemic preparedness exercise function. However, many of the reports were not publicly accessible and many of the recommendations were not implemented, which left us quite vulnerable when the pandemic eventually realized. From diagnosis, so we have lower CT scanners and MRI stocks than most other high-income countries. So we argued for urgent capital investment to address this discrepancy. But we also talked about leveraging the centralized structure and data infrastructure that the National Healthcare Service has to start developing novel diagnostics and routes to diagnosis. So our thinking was led by Sir Mike Richards, who is a previous National Cancer Director and then a Chief Inspector for CQC and now Chair of the CQC. And he outlined this vision of how diagnosis should change over the next decade, which has specific recommendations for primary care and secondary care and the use of artificial intelligence. However, we were particularly conscious when putting together this recommendation that there is a push for earlier diagnosis through a range of different mechanisms, whether it's direct access to specialists through mechanisms beyond just the GP, whether it's community pharmacy or other allied healthcare professionals, or even using AI algorithms for GPs to have direct access to certain diagnostics or specialists. But there is a danger to using these novel routes to diagnosis in that it can lead to overdiagnosis, which can significantly increase demand for healthcare services and lead to a cascade of unnecessary tests. So we talked about the idea for trying to co-develop a dialogue with the public around the benefits and risks of diagnosis, and also making sure that any efforts to use novel routes to diagnosis were subject to continued evaluation. So focusing on our data infrastructure and capabilities and capacity, we have a broad range of data sets available in the UK healthcare system, and many people would argue that they are underutilized to inform local healthcare service delivery and quality improvement. So we argue for a UK-wide data and statistics strategy that would help map priorities to leverage these data sets, but also how to integrate data sets and streamline data access, because currently our data access is extremely tedious and can often take up to a year or longer to access relevant data sets for research, and almost impossible to access for more short-term quality improvement. And we talked about trying to strengthen and rebalance our research and innovation efforts towards healthcare service delivery and not just academia and broader research. So we talked about having local healthcare data environments where different data sets are collated at the local level and accessible by frontline clinicians and data scientists working in hospitals and local commissioning boards. And this has begun to be realized in the last few years, although there are still many obstacles to overcome. But what's embedded within this is the idea that all patients should have access to their electronic healthcare record, and it should follow them from primary, secondary to social care settings. But underpinning all of this, we need to make sure that there are actually data scientists that are with the capabilities to analyze this data at the local level. The ultimate ambition is to develop the so-called learning healthcare system. So we published a whole separate report on what it would take for the UK to transition into a learning health and care system. And then finally, the integration agenda remains prominent within the UK healthcare system. However, there are still a range of different structural and financial barriers which prevent this being realised in reality. So one of the things that's driven a shift towards care in the hospital rather than the community, despite the policy imperative being the opposite, is the fact that activity-based funding in the hospital sector has driven activity in the hospital, but meant that activity outside the hospital has remained stagnant. So we talked about different options for provider reimbursement, whether it's bundled payments is one option, or pooled budgets between primary and secondary care to promote integration. But crucially, there has to be some mechanisms that allow public accountability at the local level. Unfortunately, we've seen Healthwatch disbanded in England recently, so there is a lack of opportunities for civil society and the public to hold providers account for what they are responsible for delivering. So we outlined different options to do so, including legislative reform, which would map the responsibilities of the healthcare service more clearly and allow the public to hold providers and commissioners to account. But ultimately, our long-term objective is that there should be single public entities responsible for managing budgets and healthcare delivery in primary, secondary, and long-term care. This is happening now with integrated healthcare boards. However, the budgets are still earmarked by sector, so we are still a long way off to joint budgets. So through all of these experiences that I've had over the last 3-4 years, these are my general reflections on the healthcare system in the UK. So I think it's important to note that many of the challenges and opportunities facing that UK healthcare system are not specific to the UK. They are applicable internationally. It's probably more helpful to think about the specific context and system in the UK and what advantages the UK has and how it can be leveraged. So ultimately, the UK has a very efficient model for healthcare delivery. It has a single payer centralized system with broad-based progressive taxation, and that means that generally it's quite efficient. If you look at the administrative costs in the UK compared to other healthcare systems, we have one of the lowest administrative costs compared to other systems that are based in more private health insurance or social health insurance systems. We also, with this centralized system with similar institutions, we can leverage our data infrastructure to promote efficiency of healthcare delivery even further through using data generated to inform local healthcare service delivery improvements and quality, but also driving research and innovation. However, the healthcare system remains very politicized in the UK. It has been said that arguably the NHS is seen as a religion by the public. It's the one public service which the public seem most animated about and receives a significant amount of media attention on a weekly basis. There remains high levels of public support, but because of the politicized nature of the healthcare service, we're not seeing this long-term planning that's needed to deliver a sustainable and resilient healthcare service. Instead, we see this feast and famine approach to healthcare funding. We see workforce planning that doesn't take into account changes in healthcare demand or changes in task shifting between different groups or technological developments. So there is almost a lack of long-term centralized oversight to the healthcare service. It's much more focused on short-term priorities, which as politicians are often focused on the next 3 or 4 years rather than the next 10 to 15. And it takes 10 to 15 years to train a hospital consultant. So there's a mismatch here. So the future sustainability is reliant upon politicians being transparent and honest regarding the resources that are required. I would not argue for earmarked funding, because I think that leaves the healthcare service very vulnerable during recessions or acute economic shocks. But we could have targeted funding. So we could say that we're going to generate this amount of resources and this will be allocated to the healthcare service. However, still leave opportunities to redirect resources from other resource generation mechanisms if necessary. But ultimately, it comes down to this foundation of what does long-term planning look like and what's needed to integrate financial and workforce planning, as well as capital investments in hospital infrastructure, diagnostics, and digital health. So that brings me to the end of my presentation, and I'm hoping that gave you some interesting insights into some of the challenges that we're facing in the UK at the moment. And I'm hoping that many of those resonate with the context in Singapore, for example, rising healthcare spending, changing healthcare demand, the shift in terms of digital health, and the push for integration. So I'm going to hand back to Kima, and I'm happy to answer any questions on the relevant initiatives that I've been involved in or the specific context in the UK at the moment.
Thank you so much, Michael. It's been a most interesting overview, not just of the current situation of the NHS, but also of other relevant initiatives in terms of the comparative evaluation of health system performance. We have a number of questions. So I will read the anonymous ones first, and then I will give the floor to some of the people who have are named. Let me just read a couple of them that maybe probably make it a bit more agile. So one is in the charts and graphs, there isn't any mention of Singapore healthcare spending. Where does Singapore stand in comparison to the UK? And there's another one, I presume to a degree related. Could you please touch upon what do you see as the root causes of lengthy waiting times for elective surgery and procedures in the UK? And the argument is that in Southeast Asian countries with other financing models, some of them lower middle income countries and lower numbers of consultants, elective surgery can effectively be scheduled within weeks of the referral. So probably an idea, your impression about the relative standing in terms of funding and effective funding of services comparative UK and Southeast Asia.
Okay, yeah, so a number of very interesting questions here. So first of all, so yes, there is a concern at the moment in Singapore that healthcare spending is rising, but Singapore still remains an outlier in that compared to other high-income countries, in terms of percentage of GDP, healthcare spending in Singapore is lower than many other countries. And the same applies for long-term care spending. And I think that's for a number of reasons. So one, the size of the Singapore economy does have some influence because a lot of these metrics are used as percentage of GDP, but also culturally, I think in Singapore, there's probably more elderly relatives that are living with their children, which is not necessarily the case in the UK, which leads to increasing demand for long-term care. And then the question on waiting lists. So this is a question that's puzzling health policy analysis in the UK at the moment, because we had long waiting lists before the pandemic, and that was because of that long period of austerity where you could see on the graph that there weren't really, that the healthcare spending was basically stagnant, and demand for healthcare services normally rises by 3 to 4% a year. So that the waiting lists gradually crept up to 4 million from around 1 million in the kind of the decade before the pandemic. During the pandemic, it went up to 7.5 million, and that was mainly because of the pandemic, because we saw that healthcare services were reoriented to prevent the transmission of the COVID virus, so the productivity dropped significantly. You could do less cases in the theatre. Since a lot of the restrictions have lifted, for some reason, productivity has not gone back to what it was before the pandemic. So we call it this productivity crisis, where we're trying to find out ways to improve the productivity of the healthcare service because it has dropped so significantly. So there's there's a range of different initiatives that are trying to achieve this. The surgical hubs is one of them. We're trying to put in place specialized surgical hubs to do this. But if we don't solve this productivity crisis, it means a lot of those funding projections that I outlined, 4%, even 4% won't be enough. So it is a major concern. I'm conscious that I want to have time to answer a few more questions.
So I'll also combine two more, and I'm also aware that we have just 4 minutes left. One of the next questions is whether perhaps too much money is spent on structural reform in the NHS rather than in service, innovation, and change. And if I may add a curveball there, also whether the new the closure, the now extinct NHS England, and then invigoration of the Ministry of Health, the Secretary of Health making decisions about healthcare, whether that also will significantly change the scene or not. There's also a question about why social care is neglected. I'm aware of the time, so I'll let
yeah, no, I can go through those.
Yes, yeah. I'm giving you a menu. Happy for you to respond to the one you'd like to choose.
Okay, so I think to remember, I ended the talk talking about the politicized nature of the NHS and how that in itself hampers long-term workforce planning, and that was the reason why NHS England was established. So NHS England was meant to be independent of the government, and it was meant to promote long-term planning in the healthcare service. So the fact that it's been abolished and now responsibility of the healthcare service has gone back to the Department of Health and Social Care generally makes me quite concerned that it will become even more politicized, and that means that that will hamper the long-term planning that I mentioned. The question around social care, the reason why it was neglected at the expense of the NHS is a lot of the revenue for social care is generated at the local authority level through local taxes rather than national taxes. And so as a result, local authority spending has been under more constraints than national spending. But also it's because of the attention the NHS gets. I mentioned that people argue that it's a religion in the UK to some extent, and it tends to get prioritized over other priorities like social care. And then Kima, remind me the first question that there was 3 questions.
Was in relation to whether, related to this, I mean, whether too much money was spent, or more money than necessary,
yeah, of course,
structural reform rather than innovation and change, and in particular in active skills building for managers and professionals.
So again, this comes back to the politicized nature of the NHS, because there's a new politician that always wants to have their mark on the healthcare service. So they argue for large-scale reorganization. So there's a very well-cited paper that Kim is probably aware of in the Royal Society of Medicine, which describes the repeated disorganization of the NHS, which is it's normally every 10 years, but in this case, it seems to be happening more rapidly. There is another reorganization of the NHS, and we go in cycles. So, and we repeat the same policy ideas, and we waste huge amounts of money doing so. And people often become redundant and lose their job, but then get rehired after their redundancy within the new institutions. So it's very destructive, and it's a significant waste. And it's so you should reorganize with caution, and hamper any politician's ambition to do so, and think very carefully about the objectives before pursuing such reorganizations.
Okay, thank you very much, Michael. Unfortunately, we don't have time for more. I'm not completely certain whether we may be able to answer these questions offline. I mean, in written form. We'll see whether that's a possibility. Thank you very much for everybody who asked questions, and also to all of you who joined us today. We're very much looking forward to also to continue working with Michael on other projects as we've done in the past, and we're currently working on low-value care in the provision of low-value care in Singapore. And please join me in thanking Michael very much for your fantastic seminar today, and very much looking forward to further collaborations. Thank you very much, Michael.
Okay, thank you again.
Thank you. Bye-bye.
Bye.